it okay if I record? Yeah, all right. All right. It is like class. All right, class. So I'm just gonna cover some the pancreatic slides, just kind of going through briefly or quickly through some of the relational anatomy. So in terms of the pancreas, where it's located, um, so you just have to understand the lie of the pancreas, how the head is more anterior, sits in the C loop of the duodenum. Um, the pancreas itself, the majority of it lies in the retroperitoneum, so it's more posterior. So the head is more anterior in the perirenal space. Um, and then it angles out towards the left and starts running more posterior towards the hilum of the spleen. So spleen is not visualized in this picture. We can see the left kidney, but oh, there's the spleen. So spleen's up here. So again, it runs more posterior back towards the spleen. Um, but really, I've found a lot of board questions focus more on the vascular anatomy, understanding how the vasculature, again, delineates and separates some or creates some of the borders of these various organs. Um, so aorta and IVC are both going to be, posterior. So the pancreas is going to stay anterior to both of those vascular structures. In terms of the portal vein, we know that the portal vein is made up of the splenic vein, so we could see along the posterior border. So when we're scanning, we know when we're transverse pancreas, we see that splenic vein posterior to the body and tail of the pancreas, draining into or connecting with the superior mesenteric vein to form that portal vein. Um, the portal venous system is considered the posterior border of the pancreas. The celiac axis, when we're getting that transverse picture, we can see that the celiac axis and its SMA. Celiac axis creates that superior border, so it's situated above the level of the pancreas in most patients. So if you can image or see like the wings of those seagulls, celiac and transverse, you can angle more inferior, and typically the pancreas should come in. So we say celiac axis serves as the upper border or superior border. The splenic vein, we know, creates the posterior medial border, particularly when we're talking about the body and tail. Um, so to look a little closer at some of that anatomy now. So again, here's the celiac artery off the aorta, creates the superior border, runs along the superior border of the pancreas. Um, when we're looking at the head of the pancreas, we could see the head here, again, sits anterior in front of the IVC. It's just to the right of the portal confluence. So again, think your transverse image. It's to the patient's right of the actual portal confluence. You see the dark anechoic circle in the head of the pancreas. It's inferior to the main portal vein. So superior, inferior. So the head kind of wraps around a little bit and it's inferior. So it's a little bit lower than the main portal vein itself, as well as inferior to the caudate lobe of the liver. So sometimes you can clip a little piece of that caudate in your image. It's medial to the duodenum. So this is that C loop of the duodenum where it comes down, and it kind of sits right in there, like right in the lap of that C loop of the duodenum. So the neck is the next segment. So neck only constitutes really only a small portion of. Oh, I'm sorry, skipped ahead. So uncinate process. So uncinate process. We know that this is a small segment of the pancreatic extension of the pancreatic head, where it's the curved tip of the head of that pancreas. So kind of again loops back underneath. Uncinate process also lies anterior to the IVC, so it's in front of the IVC, but it's posterior to that superior mesenteric vein. So when you guys did your sagittal, picture for pancreas now. When you opened it up to get the SMV, we saw a little piece of that pancreatic tissue posterior to the SMV. That's our unsnake process. So unsnake process is posterior to the SMV, or another way to say it, the SMV is anterior to the unsnake process. So SMV also, when we did that long picture of the pancreas, so if you kind of just visualize, that this picture that we're opening up now, if we're, transverse, we could see the unsnake process. When we turn it sagittal, what we're actually seeing is that vessel coursing and then a little bit of that neck pancreatic tissue above it, the vessel, and then some of that unsnake process underneath it. So posterior to it. So if you're just kind of visualizing, you're taking a thin slice, right over that area, what you actually see. First thing you see is some of that pancreatic tissue, then the vessel underneath it, and then behind the vessel, you're getting some of that unsnake process. So again, neck is only a small little portion of the pancreas. So it's a thin strip, located between the head and the body. So oftentimes, it's included as part of the body. It's found directly anterior to the portal confluence. So in transverse, we got that nice circle where the vessel kind of dilates and bulges where the splenic vein connects. So it's the portion of the pancreas that's just above, that portal confluence. So it's found directly anterior or in front of the portal confluence. And it's also superior. So again, relational anatomy, SMV is coming up, so it's going to be superior to that SMV. The portal confluence is again the beginning of the main portal vein that we know is formed by the junction or coming together of the SMV, superior mesenteric vein, and splenic vein. Right, so body of the pancreas. It's the largest section or largest portion of the pancreas. Again, the pancreas or the body lies anterior now to the aorta. So now again, the pancreas, it's midline, a little towards the right, and then angles out towards the patient's left. So technically it's anterior to the aorta now. Whereas the head and the body were anterior to the IVC. I'm sorry, the head in the unsnake process were anterior to the IVC. So bodies would be considered anterior to the aorta now. It's also, again, sits anterior to the celiac axis. The celiac axis or the splenic artery makes the superior border. So again, know that the splenic artery is tortuous. So that's again something that's a good indicator that you're imaging or they're asking you about the splenic artery. When you see that word tortuous, it creates that upper border, that superior border, runs along the superior border of the pancreatic body. Splenic vein, we know, forms the posterior medial border of that pancreas. So when we're imaging an ultrasound, we see it underneath or posterior to the body and tail of the pancreas. Also, the antrum of the stomach also creates an anterior border as well. So it sits posterior or behind the stomach. So stomach is going to then be in front of that of the pancreatic body. Getting into tail. There. So tail begins to the left of the lateral border of the aorta, extends all the way out, going towards the splenic hilum. Splenic artery again continues to form that superior border, posterior border. That's created by the splenic vein. The stomach again is also part of that anterior border. So that front border is created by the stomach. So again, all these organs are kind of sitting in these nice little pockets. So superior to the pancreas, splenic artery. Posterior, we have the SFV, so artery. anterior, sliding vein posterior, and the stomach in front. That's it. Sorry. In terms of ducts, we got two ducts, ducta Wirsung and ducta Santorini. So the main pancreatic duct or the main pathway or drainage of these pancreatic enzymes is going to be via the main pancreatic duct, then also referred to as the ducta Wirsung. This courses the entire length of the pancreas, going all the way up from the tail, through the body, through the neck, down into the head, and then it takes a little dip down, and runs kind of superior inferior, and takes another loop and heads towards the ampulla vader, where it eventually connects with common bile duct. The second duct is the smaller duct that's only drains the upper anterior head of the pancreas. This is the ductus Santorini. So when we get into obstruction, of the pancreatic ducts, you have to just keep in mind that things are kind of draining, in this direction and out. So everything like, pancreas creating its enzymes, they're small little channels that we're not seeing. So kind of think of this as almost like venous drainage, where you have smaller little channels that are draining into that main duct, and it's all channeling and funneling in that direction. The ductus Santorini drains out that way, and then eventually out through the ducta Wirsung. So again, what else to know about the ducta Wirsung or the main pancreatic duct? It receives its tributaries from lobules at right angles, enters the second part of the duodenum, where it's joined with the common bile duct at the ampulla vader. There's a muscle that actually controls the flow of these pancreatic enzymes and bile. That muscle is known as the sphincter of Oddi or Oddi. So then here we have the gallbladder. So I know we're starting to cover gallbladder now. Gallbladder also contains bile, which also helps in digestion of food. Pancreas also secretes enzymes that are help to digest and break down proteins. So again, when we eat, pancreas is working, secreting those enzymes, as well as secreting enzymes necessary for controlling and regulating blood sugar levels as well. So we don't always need those enzymes working. We don't always need them, in our system. So that's all being controlled and regulated by this muscle, the sphincter muscle that will contract or constrict or dilate, depending on the needs of the body. So again, just those two terms, try to memorize. Ampulla vader is where the ducta Wirsung or the main pancreatic duct joins the common bile duct, the CBD. They're joined at the ampulla vader, where it drains into the duodenum. So again, this is the first part of your small intestine here. So again, that's where digestion, starts to begin. That just kind of makes sense. You eat your food, gets passed into your duodenum. The body now needs those digestive enzymes to start breaking it apart. So the food kind of gets all mixed up with those digestive enzymes, and the body starts doing its work. So kind of like, think of it as a car wash now, you're entering into your car wash, you get that first coat of soap, over your food, the body starts digesting it. Now it's got that coat of, digestive enzymes, and it's working its way now through the digestive tract, where it's being now broken down. So again, those are the main terms. Sphincter of Oddi, sphincter of Oddi, is the muscle that controls, or the gatekeeper for those both pancreatic and biliary secretions, and they come together at the ampulla vader. So in terms of, pancreas, these are some general size measurements. So our pancreas, should be a nice nice homogeneous echotexture, so a nice even exotexture. Um, it's pretty hypoechoic, especially in younger patients, to the liver. So here you can see a portion of left lobe of the liver, very similar in echogenicity to it. Um, Older we get, the more echogenic it tends to become. Uh, so that can either be due to, potential fatty infiltrate or, potential fibrosis of it. But they usually echogenicity starts to increase the older we get. If it's a really young patient, might look a little more hypoechoic potentially, but it's usually pretty similar to that of the liver echogenicity, maybe slightly above. Again, like I was saying, echogenicity. So adult pancreas is going to be usually pretty isoechoic, or maybe a little bit brighter than the normal liver. Like I said, younger children might appear a little hypoechoic. Um, Again, nice smooth echo texture, nice homogeneous even echo texture. So there should be no, cystic structures within there. There should be no irregularities in that echogenicity. It should be very homogeneous. Um, Vascular supply. Um, so in terms of vascular supply, there are a couple of vessels involved that are branches off of the celiac axis. So coming off the celiac axis, we also have an anterior and inferior pancreaduodenal arteries that supply the head and part of the duodenum. The splenic artery supplies the body and tail with some small branches that course off. So again, we said that splenic artery creates that superior border, so it sits above superior to the pancreas. Little branches come off and supply blood flow to the body and tail. So this was our celiac axis. We have that common hepatic artery branching off, and then we have some of the branches that come off. But here was that a branch off of that GDA, so the gastroduodenal artery. We see here branching, and then we get a further branching of that gastroduodenal artery into the anterior and inferior pancreaduodenal arteries that supply the head and part of the duodenum there. Coming down, we have, I'm sorry, so that's the anterior pancreaduodenal artery. We have an inferior pancreaduodenal artery that's actually a branch now that comes off of SMA. When we get into abdominal vasculature, there's something called a pancreaduodenal arcade, where we have anastomoses and connections that exist between these vessels. So that comes around, loops around, and has connection back to here. So these vessels here are actually interconnected, and have sources off of the celiac and off of the SMA. So if we ever have any issues now, with SMA being occluded or blocked, we can still supply the lymph with the pancreas via that branch coming off the superior mesenteric artery. So there's connections or alternate pathways, so they kind of loop around and are interconnected. So kind of think of it almost like, circle of Willis. These pathways, vascular arterial pathways, are interconnected. Which vessels drain the pancreas? So venous drainage is through tributaries of the splenic and superior mesenteric veins. So small little branches drain all or leave the pancreas or branch off the pancreas and then connect into the splenic vein as well as portions of the superior mesenteric vein. So venous drainage is via the splenic and superior mesenteric veins. So small little tributaries that drain into those vessels. This is just showing a little more, detailed of some of the vasculature. So with pancreas, sometimes, as we know, it can be difficult to image on ultrasound, particularly depending on patient's body habit is, like bowel gas, if they just eaten, body habits, larger patients tend to be a lot more challenging, a lot more difficult to image. Um, but we do have our useful landmarks that can help us to, be able to kind of get our bearings, be able to make our visualization, of the pancreas and the various structures. But again, look for celiac access if you can, then angle it here and go down. Sometimes I'll have it come in. Look for your superior mesenteric artery. That's got a good landmark to try and orient yourself. If you have nice clear pictures of the pancreatic head, you can image things like the gastroduodenal artery, common bile duct in the head of the pancreas. Use the portal confluence and the SMV or splenic vein, again, as your landmarks to help delineate the borders of the pancreas. The first picture here, we're in transverse now, so we're going to be superior above the level of the pancreas. This is again that seagull sign showing the celiac artery as it's coming off the anterior surface of the aorta, branching out towards the left, your splenic artery going out to the right, the common hepatic artery. So from this point, we probably have to just angle ourselves or orient ourselves a little more inferior. So kind of tilt down a little bit now to try and get that pancreas. In sagittal, we could see again our image of our aorta. You can see our abdominal vasculature coming off the aorta, our celiac artery, or SMA. So this was our transverse pancreas picture. So here we could see a very prominent gastroduodenal artery, as well as a prominent common bile duct here in the head of the pancreas. Rotating now, if we're to rotate on that and try and open up our common bile duct. So now we're getting into more of like a sagittal oblique. You can visualize our common bile duct running out towards the head of the pancreas. Here we can see a little bit of pancreatic tissue, kind of more of a sagittal oblique plane. But it makes sense that common bile duct we know courses through the head of the pancreas. Go back to the picture here. That common bile duct is coursing through the head of the pancreas, so that's what we're seeing when we take those transverse slices, and we see the common bile duct as a circle that courses through the head of the pancreas. Back. You can see visualize there a little bit of pancreatic tissue on either side. So some congenital anomalies. So agenesis. So this is basically when the body fails to form an organ or fails to properly, form an organ. So patients who have agenesis of the pancreas, there might be agenesis of the body and tail, with some hypertrophy of the head. So meaning that the head is going to be larger to compensate for the missing body and tail in this case. The body's still trying to produce a sufficient amount of both, endocrine and exocrine enzymes. So again, this is considered congenital defect now. If a patient has complete agenesis of the pancreas, this is a very rare occurrence and will be considered a lethal condition. They're not producing those vital, enzymes that are needed for, forcing digestion of foods, staying alive, controlling and regulating blood sugars. So, unfortunately, that's not going to be compatible with life if there's a complete agenesis of pancreas. So like I said, if it's malformed and it hasn't created a body and tail, the head itself is going to be much larger than you typically find. So this was just showing a CT, a patient had just some pancreatic tissue there in the head and absence those X marks where you'd expect to see the tail. Something that would be a little more common would be what's called ectopic pancreatic tissue. So meaning that, we expect to see the pancreas in a particular location, but that pancreatic tissue is actually located elsewhere. Um, so this is the most common anomaly when we're talking about congenital pancreatic anomalies. So there's presence of pancreatic tissue in the gastrointestinal tract outside the normal confines of the pancreas, and lacking any anatomic or vascular connection with the pancreas proper. So in these cases, patients might have a little bit of normal, or have a normal pancreatic tissue, and then an area of pancreatic tissue that exists outside of that normal um, proper pancreas. We can get splitting of the pancreas, so pancreas divisum. It's when the ducts of Wirsing and duct de Santorini fail to fuse normally. So now, like I said, normally the duct de Santorini is just draining that anterior portion of the head and connects into the duct of Wirsing. In this case, the duct of Wirsing, the main pancreatic duct, is small and drains only the inferior portion of the pancreatic head, and the duct of Santorini ends up draining the majority of that pancreas. This is now showing that duct of Wirsing, instead of typically draining the whole pancreas and then diving down and draining a portion of the head, it only is relegated to that small portion of the head. That duct of Santorini is the main pancreatic duct now that's draining the body and tail of the pancreas. Another congenital anomaly is annular pancreas. So this is also a rare anomaly where the head of the pancreas grows around or surrounds the duodenum. So rather than just sitting typically here in the seat loop of that duodenum, some of the pancreatic tissue starts to grow and wrap around the duodenum. So this is what's referred to as annular pancreas. Fortunately, this could result in issues with obstruction of the biliary tree, as well as compression of the duodenum. So now you've got pancreatic tissue now that's growing and wrapped around. It could potentially put compression and squeeze the duodenum, preventing adequate emptying of the stomach. So these patients might have or probably will have some sort of digestive issues, maybe some sort of reflux going on. They might be undernourished or dehydrated because there's a lot of that compression of the duodenum there. This is a condition that's more common in males. We're going to start building those uncommons or most commons. Patient population affected, annular pancreas. So in this case, it's a little difficult to kind of visualize. So you're imaging, you see some pancreatic tissue. We start to recognize, duodenum and stomach on ultrasound. We see some pancreatic tissue that connects on the other side of the duodenum there. So we got the head of the pancreas and some pancreatic tissue protruding up. And we see on the opposite side of the duodenum where we not expect to see pancreatic tissue. There could be some positional variations in terms of the lie of the pancreas. So this is just kind of going over some of the various, potential differences in lie. So you guys have experienced some of that. Some of you guys, they're a little more tailed out. Some of your pancreases are a little more, inverted, maybe a V shape. So again, not everyone's the same. In terms of the physiology, so again, pancreas, holds the distinction of being one of the organs that's both an exocrine organ as well as an endocrine organ. So it has dual functions. So it produces digestive enzymes through its exocrine portion, aiding in the breakdown of food. Then it also secretes hormones like insulin and glucagon through the endocrine portion. So those hormones get put directly into your bloodstream. That's the endocrine function directly into your bloodstream. And then the exocrine portion excretes those digestive enzymes directly into the duodenum for digestion. I'm kind of just breaking that down, exocrine versus endocrine. So exo, again, that prefix means outer or external. So the digestive tract, so i.e. the digestive tract eventually sends stuff out of the body. So pancreas releases juices and enzymes that enter the duodenum. That's essential for digestion and absorption. So mainly digestion of proteins and some fats. Some carbohydrates as well, but primarily protein digestion. Pancreas is also a hormonal gland, so it's part of the endocrine system as well. So these hormones circulate within the bloodstream within us. The pancreas is responsible for secretion of glucagon and insulin into the bloodstream. That's essential for regulation of our sugar levels. So again, when our sugar levels get too low, releases glucagon. When our sugar levels get too high now, pancreas starts releasing the insulin to bring them back down. So exocrine function. So now we're talking about the digestive enzymes. So the pancreas has certain cells which perform the exocrine functions. So when we're talking about the exocrine functions of the digestive enzymes, these are produced by the acinar cells. The acinar cells produce and transport chemicals that will exit the body through the digestive system. Then these enzymes are secreted in duodenum where they assist for digestion of food. The acinar cells produce about 2 liters of pancreatic juice per day. That's a pretty significant amount. The acinar cells are arranged in acinic clusters and are connected by smaller ducts which connect to the larger pancreatic ducts. So think of these little cluster grapes, these cells being like these little cluster grapes that have small drainage ducts. So they produce the enzymes, drain into smaller ducts that then eventually connect into your ducta orsum or your main pancreatic duct, or maybe it's the ducta santorini. And again, these will then drain through the ampular or connect to the common bile duct and through the ampular evader, through the sphincter of Oddi into the duodenum. So in terms of the specific enzymes, again, the main enzymes, that the pancreas makes are amylase, trypsin, and lipase. They also make nuclease, which breaks down nucleic acids. But primarily, we're talking about carbohydrates, proteins, and fats. Then this is one of the main ones that produces the proteins and fats. So amylase. Trying to think of the best way to kind of break down. So lipase is easy. Lipase, I think lipids are fats. So lipase breaks down the fats. Trypsin, I don't know why I think of like Thanksgiving dinner when you get lazy after Thanksgiving and you've eaten the turkey. They call it tryptophan, that hormone that like makes you tired and lazy after Thanksgiving. So that's how I kind of correlated to proteins. Trypsin, it breaks down the proteins, and then amylase breaks down the carbohydrates. Good way to think of amylase. So amylase, I don't know, I'm kind of just going back in time. Like I think amylase, ATP, energy, carbohydrates give you energy. Maybe that'd be a good way to kind of remember that one. But anyway, yeah, these are the digestive enzymes: amylase, trypsin, lipase. The reason these are also important as well is because when we do lab work on the patient or workups, we could see potential elevated lipase levels, elevated amylase levels, you know. So these are some of the things that we look at when they do a CBC or a workup on a patient to potential see if there's any issues going on with the digestive tract. So other enzymes that are important to know, these enzymes aren't produced by the pancreas, but other digestive organs. But since, you know, they're the pathways through the head of the pancreas, issues with the pancreas can also affect, you know, some of these other organs as well. So mainly talking about cholecystokinin. So this stimulates the secretion of pancreatic enzymes, as well as leads to the construction of the gallbladder. So cholecystokinin, when we eat, the body releases this stimulus, this enzyme. It acts on the pancreas, stimulates the gallbladder contract. Secretin stimulates the secretion of bicarbonate. This neutralizes acids and bases. The stomach makes gastrin. There are some additional enzymes. This stimulates the secretion of gastric acids for digestion. All right, so then just to recap, exocrine, produced by the Acini cells or Acinar cells, Acinar cells, produces lipase, amylase, and trypsin. Endocrine function now. So with the endocrine functions, there are specific cells that now produce these hormones. The endocrine cells are the alpha, beta, and delta cells. Where are they found? So this is, again, just important. You have to know the difference. So the acinar cells were the exocrine. The islets of Langerhans are where these exocrine cells are located. I'm sorry, endocrine cells are located. So endocrine cells, the islets of Langerhans are the ones that produce those endocrine hormones. The exocrine are formed by that acinar cells. So I don't know if anyone's ever seen, like, you know, in any of your bio classes when they are stains about pancreatic cells. So you have the main endocrine glands here, the islet of Langerhans, surrounded by those cluster of grapes, those acinar cells surrounding the islets of Langerhans. So this is kind of like one larger, like, functional unit in a way, in the way the pancreatic cells are arranged. So what exactly do alpha, beta, and delta cells do? So the alpha cells are the ones that secrete the glucagon, which is used to raise our blood sugar levels. So we're not eating a long time. See, feel our body senses our blood sugar levels are starting to drop. The pancreas is going to release. Those alpha cells are going to be stimulated to release glucagon. So again, these are the hormones that you have to, be familiarized and memorize. That makes sense. You know, glucose, blood sugar, glucagon is what raises our blood sugar. So insulin, the beta cells are the ones that produce insulin now. This is responsible for lowering our blood sugar. So after we eat, a high caloric meal, our blood sugars start to go up. We don't want them spiking too high, so the body sends message for the beta cells to activate to release that insulin into our bloodstream. So the insulin then reacts with the sugar molecule, those glucose molecules, to create glycogen, and then that glycogen is sent to the liver for storage. The beta cells are more prominent, are more prevalent within the pancreas, and then the delta cells, these secrete somatostatins, which is an autoregulator that and inhibits the production of both insulin and glycogen. These cells are the smallest components of the endocrine tissue. So think of this delta cell as kind of like controlling these guys now. So these guys, they're smaller overall portion of the whole system, but they are responsible in that autoregulators of inhibiting the production of both insulin and glycogen. So in terms of overall numbers, 99% of the pancreas performs the digestive part of it, those exocrine functions with the acinar cells, and then 1% of the total, function of that pancreas is responsible or occurs in the it's a Langerhans with the endocrine functions. So lab tests, like I said, so it's important to familiarize yourself with these enzymes because these are some of the markers that we look at when a patient comes into the hospital or to a doctor's office. So they might be sent to you for an exam to assess the pancreas because some of these blood works. That's kind of funny. I'm getting a message from my LabCorp bill is due, so I'm talking about this. So again, part of some of the workup on these patients. One of the things that we look for, particularly when we talk about pancreas, are going to be our serum amylase and lipase levels. So it's serum in the blood, our blood amylase levels. We can look at urine amylase levels and look at our glucose levels as well. Are the glucose levels out of whack? The reason for this is because there are specific enzymes that the pancreas, like these specific enzymes might be altered in the presence of pancreatic disease. So again, if the pancreas becomes inflamed through pancreatitis, infected, damaged, these enzymes potentially leak out, causing abnormal lab values and results. So amylase, then the digestive enzyme, which helps to break down the carbohydrates that we consume. So what does a elevated or increased serum amylase potentially indicate? So in certain types of pancreatic disease, the digestive enzymes escape into the surrounding tissue, which can produce necrosis with severe pain and inflammation. This will show an increase in serum amylase. If there's maybe potential pancreatitis that's developed, or there's blockage of our, of the drainage ducts. So if there's a blockage, in the ducta Wirsong or ducta Santorini, or potentially even, something in the CBD, where it connects, this could potentially back things up and then cause leakage of those digestive enzymes and damage the surrounding tissue. A serum amylase level of twice normal usually indicates acute pancreatitis. So again, we use these markers to help make that diagnosis of acute pancreatitis. It will remain elevated for about 24 hours in these cases. Some other conditions that might increase patient's serum amylase. You said chronic pancreatitis. So just think pancreatitis in general will raise your amylase. So whether it's an acute or chronic pancreatitis, both ways you're going to have an elevated serum amylase. So if it's acute pancreatitis, it's an acute onset of disease, something's causing it, that acute episode of pancreatitis, pancreas is inflamed, it's damaged, amylase is leaking out, it's going to be high. That will tend to resolve itself, within 24 hours, or they'll start working their way down. Patients who have had multiple episodes of acute pancreatitis and then pancreas is damaged, and now they have what's referred to as chronic pancreatitis, those serum amylase levels, might remain elevated, will typically continue to be elevated. Like I said, obstruction of those pancreatic ducts definitely, cause elevated serum amylase. Maybe a perforated peptic ulcer. In addition to that, acute cholecystitis, when we worry about inflammation or infection of the gallbladder. Alcohol poisoning can lead to abnormal serum amylase tests as well. So there are a couple other things, that can potentially indicate elevated serum amylase. So again, elevated amylase, worried about main thing, pancreatitis, and then we'll learn about the causes of potential causes of pancreatitis, one of which being, gallbladder calculi or cholelithiasis, choledocholithiasis. Urine amylase, so we can also test for elevated amylase in the patient's urine. So in this case, it also would potentially be elevated in cases of pancreatitis. And if it's from a urine sample, these tend to remain elevated longer than the blood test. Lipase. So we did lipase breaks down fats, lipids. So it's parallel in elevation to amylase to show signs of pancreatic inflammation and damage. So again, another indicator of potential pancreatitis, the inflammation of the pancreas. So lipase remains elevated for a longer period than the serum amylase, so potentially up to 14 days. So we don't have to catch it, in that tight window of 24 hours. So a patient might be experiencing, epigastric pain, I'm not sure what's going on. They ignore it for a while. We might have not catched it in that window where the amylase is elevated, but the lipase would still be elevated at that point. So elevated lipase levels, like I said, would be in the setting of acute pancreatitis. But also keep in mind that carcinoma of the pancreas can also raise a patient's lipase levels as well. Other indications or other issues with that might cause elevated lipase, again, obstruction of those ducts. So obstruction of the ducts will lead to pancreatitis potentially. And then acute cholecystitis. So you can see here how the gallbladder and the pancreas kind of go hand in hand. They're both, I don't want to say cousins, but they work kind of in tandem with each other with digestion. And then, they do have the ducts, connecting in the head of the pancreas as they drain out, again, to the ampular vator. Ampular vator's controlled and regulated by that muscle, the sphincter there, which is the sphincter of Oddi. Glucose. So we know that this is a measure of our, blood sugar levels. The glucose is the main type of sugar in the blood, a major source of energy for the body's cells. So a glucose tolerance test can be performed to discover if a patient has a disordered glucose metabolism. Increased glucose levels are primarily found in cases of severe diabetes. Chronic liver disease can also cause this as well as overactivity of the endocrine glands. If patients' blood sugar levels are exceedingly low, this could potentially indicate mass or tumor in those islet cells and the islets of Langerhans. Sonographic evaluation. So we're looking at the pancreas now. So yeah, pretty much, I'm every place that I've ever worked and every image I've ever, any images I've ever seen when we're doing a protocol, you're always going to start transverse pancreas or transverse plane, your transverse view of the pancreas. Again, just orient yourself with your landmarks. Utilize your SMA as a nice landmark. Visualize that portal confluence, your splenic vein. Of course, you're underneath the body and tail of the pancreas. Again, most patients see a portion of the left lobe of the liver interior. So again, the liver sitting in front of the pancreas. Maybe its stomach also anterior to the pancreas. So we said stomach makes that anterior border as well. And you got your nice aorta, IVC there. So indications. So why we typically do, sonographic evaluation of the pancreas. So again, every exam that we do, we need a proper indication. We need to figure out, what's going on, what's the story, why are we doing this test, So it's not just rule out pancreatitis. That's not a proper indication. Yes, that's probably what we're looking for. That's what they're suspecting. But we need to have, again, another indication on that order, on that rec. It can't just be rule out pancreatitis. If a doctor is lazy, and that's all, I hate to say they're lazy, but sometimes they are. But if that's all they put on the rec, then it's up to you to kind of take that extra step, take a look, pull up the patient's charts, look at their labs. All right, amylase is elevated, lipase is elevated. All right, that's good. I got my indications right there for doing this exam. So again, right there, elevated labs, abnormal pancreatic enzymes. We're looking at amylase, we're looking at lipase, the two biggies. Severe epigastric pain, so again, abdominal pain. Maybe the patients have unexplained weight loss or anorexia, they're not hungry, that could be, an issue again with either digestion of the food, so maybe unfortunately, they have some sort of pancreatic mass or something that's, either constricting the duodenum, they're not feeling hungry. Um, Something's constricting the ducts, so those digestive enzymes aren't being able to leave the pancreas, not able to secrete into the duodenum. So that food, that you're eating, it's not being digested. You're just kind of passing it through because those digestive enzymes are not reaching the food for it to be broken down. Um, biliary disease, if they have known biliary disease, could be an indication. Again, we're looking for, in the course of assessing the pancreas, potential for biliary disease, assessing for pancreatitis. We're assessing for, pancreatic neoplasm. So maybe it's a follow-up to a CT. They want to get a good look at ultrasound at a lesion that they see on CT. Maybe underactive bowel sounds, so hypoactive means underactive bowel sounds. The bowels aren't, peristalsing properly. And then obvious, follow-ups, like I said, we'll want to take a good look at one of these lesions that maybe we saw an MR or CT, or we're following a previous ultrasound. So how do we describe echogenicity of a normal pancreas? So pancreatic echogenicity expressed in terms of its relativeness to the liver. Normally it should be slightly more echogenic than the liver, particularly the older that you get, the more echogenic it becomes. So you guys are all fairly young, or most of you are pretty young. You see that sometimes it's really hard to delineate the border, that anterior border of the pancreas with the left lobe of the liver. It can be very tricky because they're so isoechoic. So part of the reason, also why it becomes more echogenic, we tend to get fatty infiltrate working into the pancreas itself, so that leads to it becoming a little more echogenic. The parenchyma texture depends on, again, the amount of fat between those lobules. In a healthy patient with normal organs, there should be a progression of echogenicity as follows. So pancreas being the brightest, then the spleen, then the liver, then the kidneys to least echogenic. So this mnemonic pumpkin spice latte. Okay, I think you guys had a different mnemonic. Memorize it as well. So our transverse pancreas and our normal landmarks. So it's our aorta, IBC, running vein, SMA, so transverse SMA. So this is really portal confluence going into the splenic vein. So I wouldn't label that splenic vein SV. To me, that's more portal confluence. In terms of head of the pancreas, again, see some of the structures, your gastroduodenal artery, the anterior border of the head of the pancreas, posterior part of the head of the pancreas, we can see our common bile duct. Snake process wrapping around, we said is posterior to the portal vein. Anterior to it, you can see the neck. So again, when we open up and get that sagittal view, what we're seeing is the neck and the unsnake process in that sagittal view when we open it up to see the superior mesenteric vein when we turn it sagittal. Again, just be able to identify, your structures for your transverse pancreas. Again, if you can go through and label and identify your structures, you're going to be good. So in terms of smaller landmarks that help to delineate borders, you could look for that digastric artery, the anterolateral border of the pancreatic head. The common bile duct makes the posterolateral border of the pancreatic head. So the presence of these two holes form, I guess, what's sometimes referred to as a snake eye or snake head sign. So just a little practice, can you identify again some of these structures here? So transverse pancreas, got our aorta. So, oh, I want to look at structures for the pancreas. So A, portion of the pancreatic head, oncinate process, posterior to the portal vein there, or confluence. Getting the neck is anterior to the portal confluence there. Then you get into body and then tail, portion of the tail of the pancreas. Then if you know, again, your anatomic orientations, you know, to tell the difference between gastroculateral artery and common bile duct. So sonographic evaluation. So after we do some transverse images, ensuring that we image again the pancreas thoroughly, be able to try or attempt to get adequate images, you know, the head, body, tail of the pancreas. Like I said, some of you that's easier in multiple images. Some people you can get that all, you know, nice in one or couple plus images where you see the entirety of it. Because that might not always be the case. You might have to break it up. But then try and go, and then from there you rotate into sagittal orientation. And this is labeled the sag pancreas view. In sagittal pancreas, we're now opening up, we're staying on that portal confluence, opening up where we now visualize the superior mesenteric vein. In this view, we see a portion of the neck of the pancreas, the anterior, or in front of the superior mesenteric vein, and then posterior to superior mesenteric vein, we see in the portion of that uncinate process. Um, this was some additional sonographic evaluation. So, okay, we have again some sagittal transverse views now of the SMA, the superior mesenteric artery. So again, the SMA we use as a demarcation of the pancreas, the body of the pancreas. In this case, this is our sagittal view, SMA coming off the aorta. We see a little bit of pancreatic tissue there, a little bit of the body of the pancreas. And then A here is labeled the antrum of the stomach. So we see a portion of the stomach here in that view. Transverse. We could see now the SMA transverse. I don't know if you guys are seeing me adequately. Or here, transverse. We're getting now some of the body, and then again of that pancreas, and then superior to that body of the pancreas, we're seeing the distal antrum of the distal portion of the stomach going into the pylorus, or the pyloric muscle, and then some of the duodenum off to the side. So stomach is over here and it's draining that way. So in our transverse view of the pancreas, you know, one of the things that I haven't seen in any of you guys since we were imaging pancreas is the pancreatic duct. Most of the times it's not visualized. Some patients will have a more prominent main pancreatic duct, so prominent duct of Wirsung. If it is something that is noted or visualized, Take a picture of it, obviously put some color on it just to show that it's a duct and not a vessel. And then you could take a diameter measurement, you could do an inner to inner diameter measurement to see just how dilated it is. With that pancreatic duct, so we could see it running here right down the middle of the body and tail of the pancreas. Oftentimes it's a lot more difficult to see it as it enters into the head. Part of it is, it takes that kind of that dig down, but definitely, if you're gonna notice it, visualize it, it's typically gonna be, in that more, in the body and tail. Also, you have to think about it too, in the sense that when we learned about neoplasms, majority of the neoplasms are gonna be in the head of the pancreas. So this is where the obstruction or blockage is gonna occur, and then it's gonna dilate, distal to it. So you're gonna think of it all draining, in this direction. If my blockage is here, it's gonna fly, those, digestive enzymes are gonna build up and the duct is gonna dilate, distal to that obstruction point. So that's where you're gonna see it, dilated. They give a measurement here. I will double check, but I'm pretty sure when you measure it, less than 2 millimeters is considered normal, so you're okay. It's just prominent if it's 2 millimeters. But when you start measuring something greater than 2 millimeters, this is considered dilated. Just double and triple check myself. Oh, 2 millimeters? Yeah, all right. Yeah. We got a little review. And so main pancreatic duct, also referred to as the duct of Wirsong. You have the ductus santorini that drains just a small portion of that anterior head of the pancreas. Those two converge. The duct of Wirsong or main pancreatic duct continues towards the ampulla vator. So that's that opening in the duodenum where it's joined by the common bile duct that's draining the bile from the gallbladder. We have the muscle that sits at that opening at that ampulla. So that sphincter muscle is the sphincter of Oddi that controls that. In terms of the cells, the acinar cells are the ones that are responsible for the exocrine functions, so the digestive enzymes, lipase, amylase, trypsin. So amylase for carbohydrates, lipase for fats, lipids, and then trypsin for protein digestion. The islets of Langerhans, those are the ones that are responsible for the endocrine functions. So mainly glucagon and then insulin. Glucagon raises your blood sugar, so it puts glucose into your blood sugar, raising your blood sugar. Insulin helps to lower your blood sugar levels. The insulin reacts with the glucose molecule and creates glycogen. Again, the majority of the cells, involved in the pancreas are with the exocrine function, only 1%. The function of the pancreas deals with endocrine function. So again, you familiar with those the pancreas function enzymes? Yeah, these are good telltale signs when we want to diagnose pancreatitis, as well as obstruction of the pancreatic ducts, either through neoplasm. We said amylase can also be elevated in cases of malignancy as well as in chronic pancreatitis. So chyme from the duodenum stimulates the release of hormones which act on those pancreatic juices. So cholecystokinin, CCK, contracts the gallbladder and stimulates secretion of the pancreatic enzymes. So just kind of taking a little side note, this cholecystokinin, if we're in there are tests that potentially can be done to look and assess and evaluate the biliary tree. So one of those exams is called a HIDIS scan. So it's a nuclear medicine procedure where they actually have contrast that gets uptaped into the gallbladder, and then the doctors will have the patient either eat a fatty food or they'll actually inject them with cholecystokinin to cause the gallbladder to contract, and they'll image the bile being squeezed out of the gallbladder through the biliary tree, like through the head of the pancreas, to see if there's any stones or blockages or obstruction in that flow of digestive enzymes. So again, that hormone can actually be administered, intravenously to the patient, or say intravenously. Maybe it is intravenous. I'm not 100% sure, but it can be given injected into the patient to cause the contraction of that gallbladder, as well as stimulate the pancreatic enzymes, or the pancreas to produce those enzymes. Gastrin stimulates secretion of gastric juices for digestion, and then secretin is a secretion of sodium bicarbonate. So think like baking soda, basically. It helps to neutralize, those acids and bases. So those the endocrine functions now, we had the three types of cells within the islet. So these are all considered islet cells located within the islet of Langerhans, the alpha, beta, and delta cells. We also have these polypeptide cells that regulate the endocrine and exocrine functions of the pancreas, but yeah, the primary ones are the alpha and beta. The alpha cells responsible for releasing glucagon to raise our blood sugars. Beta cells responsible for insulin production, which lowers our glucose levels. So again, some of the indications that we would look for, common indications for performing an exam to assess the pancreas. Definitely epigastric pain, elevated pancreatic enzyme labs, weight loss, loss of appetite, presence of known biliary disease. When we want to assess, and monitor pancreatitis, maybe assessing and looking for, again, pancreatic neoplasms. But again, that's not necessarily these two, are indications in and of themselves, unless we know about these things. So a follow-up to some of these other exams could be an indication. This was showing, again, some of those lab values. So again, we're looking for elevation in amylase, elevation in lipase to indicate the potential for, pancreatitis, obstruction of those pancreatic ducts. So again, I'm sorry, I misspoke before. So when lipase is elevated, this could also potentially indicate pancreatic carcinoma, pancreatic cancers. With lipase also, as well as amylase, they're also tied into acute biliary disease, so issues with the gallbladder, cholecystitis. So we can see those elevated, the acute cholecystitis as well as cirrhosis. So in this case, when patients have liver disease, this could impact your amylase and lipase as well. If serum amylase is very low, this could potentially indicate an issue with the liver, patients who have potential hepatitis or cirrhosis. But primarily we're looking for elevation, in these enzymes. Again, be familiar with your divisions. You guys are good at. So again, pancreatic head lies in that C loop of the duodenum. It's lateral to the SMA and SMV, anterior in front of the IVC. Common bile duct is posterolateral, duodenal arteries anterolateral. So we know that GDA is anterior, the anterior portion of the pancreas. Common bile duct is in the posterior lateral, so posterior portion. Neck is a small, again, just a small portion of that pancreas. So it's anterior or in front of that portal splenic confluence. So just think about it when you're scanning your transverse pancreas, that nice bullseye circle you see there. The neck is up in front of it, so that's sitting behind the neck. So it's behind this actual portion of the neck of the pancreas, and then posterior to the portal confluence is going to be the uncinate process on the other side of it. So that's where we see it wrapping around there. It's also behind the pylorus of the stomach. So the stomach again is sitting in front of. So when we're on ultrasound image, it's going to be somewhere up here because it's anterior. So again, just I know it's a little hard to kind of visualize it when you're looking at some of these anatomic images and then the sonographic image and what we're actually seeing. You know, so again, we're kind of coming at it this way. You know, we're looking at it like kind of like a bird's eye in a way. We're looking down on the structures itself. We're looking down on that pancreas. If you kind of envision it that way and what you're seeing on the ultrasound, then the thing at the top of the screen is going to be higher up or the roof of, you know, whatever it is you're looking at. So uncinate process is posterior to that superior mesenteric vein. So the SMV is running in front of or anterior to the uncinate process. It's also anterior in front of the aorta and the IVC. So we know aorta and IVC are both, you know, deeper or posterior to the the entire pancreas, but including the uncinate process. Body. So this is the most anterior aspect of the pancreas, so it's the most closest to the front of the body, and then it tails off more posterior as we go. So you see on ultrasound how the tail just kind of dips down, so it's dipping posterior, dives down or dives deeper. The body's the largest portion of the pancreas. Then just relational anatomy, it's in front of the aorta, in front of the SMA, in front of the SMV. It's in front of the splenic vein. So all these things are posterior to the or behind the body of the pancreas, including the left renal vein. But it sits behind the antrum of the stomach. So the antrum of the stomach, the part of the stomach is in front of the body of the pancreas. Then you get the tail. So this is the most superior portion, so meaning it's higher up. So it kind of, like I said, that's why we rotated slightly oblique our transducer because it runs slightly anterior, superior as it's running up. The tail then sits, extends up towards the hilum of the spleen. It's in front of or anterior to the upper pole of the left kidney. The left kidney is going to be behind the tail of the pancreas. And it's posterior also to the antrum of the stomach. So it's behind again the end of the stomach. This is again a little breakdown now of the ducts. So this was kind of a more close-up view of that ampulla vader, where we get the coming together of the duct of Wirsong, or the main pancreatic duct, and the common bile duct joined together where it enters into the duodenum there at the ampulla vader, and then that muscle that opens and closes, or opens and closes, but constricts and then dilates. So that sphincter muscle that's controlling the release and secretion of those digestive enzymes. So that's the sphincter of Oddi, or sphincter of Oddi. So the main drainage of these exocrine enzymes is via the duct of Wirsong, or the main pancreatic duct, extends the length of the pancreas, joins the distal CBD to the descending part of the duodenum, through that ampulla vader. Then we have a secondary duct known as the duct of Santorini. So this is the secretory duct. So primary secretory duct, duct of Wirsung, main pancreatic duct. Secondary secretory duct is also known as the duct of Santorini. This drains the upper anterior portion of the pancreatic head, enters the duodenum at the minor papillary, approximately about 2 centimeters proximal to ampulla vader. May not communicate. So it may or may not communicate again with that Dr. Warsong. So this was going through some, again, basics, normal pancreas, nice homogeneous echo texture. The echogenicity varies with age, so it increases as you get older. So in young children, it could appear hypoechoic to the liver, isoechoic in young adults, and then more hyperechoic when we start getting into the older populations. In terms of diameter measurements, so here at Christianity, we measure the head of the pancreas. We do a diameter of the head. We don't typically measure the body or tail. Unless of course it looks dilated or inflamed, and then we start, and in cases of pancreatitis where it is inflamed and it is enlarged, then we start measuring it. But these are some typical, diameter measurement ranges. We're talking about the body and tail. Some review questions. So go through what you can describe, the shape of the pancreas, the position of the pancreas as it occupies the abdominal cavity. So again, the majority of the pancreas lies in the retroperitoneal cavity, in the abdomen. Go back to the beginning. We got a small portion of the head that sits in the duodenum. So it's deep in the epigastrum and left of the hypochondrium behind the lesser sac of the omentum. So in terms of the lie, it's horizontal oblique lie. Let's see, got a good picture here. So again, the majority of this pancreas lies in the retroperitoneal cavity, except for a small head that's in the peritoneal cavity. So the head's in that peritoneum, and then the body and tail lie in the retroperitoneal space. So it occupies this anterior perirenal space, lies obliquely between that C loop of the duodenum, and goes out towards the splenic hilum. So we'll be able to again describe the physiology of the pancreas. So we know that it's both an exocrine and an endocrine gland. Familiarize, the exocrine functions we talked about, produced by those acinar cells, producing the amylase, lipase, and trypsin. What are the islets of Langerhans? Those are the cells that are responsible for the endocrine functions, producing. So the alpha cells produce the glucagon. The beta cells produce the insulin. Again, responsible for regulating our blood sugar levels. What role does insulin play in the pancreas? So the insulin is responsible for lowering our blood sugar levels. Primary action of glucagon is to raise our blood sugar levels. What controls the regulation of the insulin and glucagon secretions? So those are the delta cells. God. Cells. There you go. So the delta cells here secrete this somatostatin, which is the one that controls uh, the production of both insulin and glucagon. Too far. Number 7, two enzymes that we look for in those lab tests that can indicate pancreatic disease: lipase amylase, lipase amylase, lipase amylase. So anytime again you see a rec that says elevated lipase, elevated amylase, we're thinking pancreas right away. So in addition to acute pancreatitis, it could be obstruction of the pancreatic ducts, could be also biliary in nature as well. So it could be acute cholecystitis, issues with the gallbladder. So, and that's what we look for: serum amylase, serum lipase, urine amylase. Be able to describe normal echo texture of the pancreas. So homogeneous. For normal adults, it's isoechoic to the liver. The older you are, it becomes more echogenic due to fatty infiltration of the pancreas. All right, so this is not getting into the next set of slides, so don't worry about these review questions yet. Alrighty. Some ology for pancreas now. So hands down, the most common thing you're going to be looking for or assessing for is the presence or absence of pancreatitis, or evaluating a patient for potential pancreatitis. So pancreatitis, it is a pretty serious thing. It could lead to, some very serious complications. Worst case scenario, it could even be potentially, life threatening. So unfortunately, I always hated rule out pancreatitis studies, and their amylase, lipase are elevated through the roof, and they've kind of fit the bill, but they're so morbidly obese or they're a big dude, big belly, and I just gassed out. You can't see the pancreas at all, and you're just like, oh man, it's so defeating. Unfortunately, it's one of those things, like you really wish you could see the pancreas and make that, potential diagnosis, but become frustrating. Also keep in mind too, if the pancreas is inflamed, they're going to be in a lot of pain. Pancreatitis is very painful. So you're putting pressure on there, trying to image what you got to do. They're going to be not happy campers, when you're trying to do that exam. So again, just going back to your normal endings, itis, anytime you see itis, it's inflammation. So regardless of whatever it is you're imaging, when you see that ending itis, you're talking about inflammation. So pancreatitis, inflammation of the pancreas. It occurs when the pancreas becomes damaged and malfunctions. And then as a result of this, we have increased secretion and blockage of the ducts. So when this happens, the pancreatic tissue may actually be digested by its own enzymes. So like I said, these enzymes that it's producing, they're there to digest fats, proteins, carbohydrates. So your organs are proteins, and sometimes they're comprised of fats as well, but primarily proteins. And these enzymes will break down the organ. They're designed to break down food, but they'll also digest and break down the organs as well. So that leads to damage of the organs. When we're assessing pancreatitis, we break it down into two classifications. We have acute and then chronic. Episodes of acute pancreatitis we can further classify as mild, moderate, or severe, depending on how inflamed, how thickened that pancreas is there development of pseudocysts at this point, like how much damage is being done. We could kind of potentially further classify it. So causes of pancreatitis, the most common cause in the US is due to biliary tract disease. So in these cases, about when a patient does have acute pancreatitis, so again, acute, we're thinking sudden onset, this is the patient, never had any real issues before. All of a sudden they're developing intense epigastric pain. Their blood levels all of a sudden spiked up. So again, this isn't something that they've ever experienced before, or maybe they have experienced this before and they're having another acute episode. So again, they could have, patient could kind of know what's going on, have had this incidence before. But again, most of the times, or more than half the cases involved a gallstone being present. So either gallstone, somewhere stuck in the common bile duct, maybe stuck right at that ampulla vader, right there, before it enters into the duodenum, gets lodged there. And then that causes everything to back up. We don't get proper drainage of the pancreatic ducts. And then that leads to the secretion of those enzymes and damage to the pancreas. Second most common cause, unfortunately, is alcoholism or alcohol abuse. So that alcoholism, unfortunately damages the pancreatic cells and can lead to the development or release again of those pancreatic enzymes and episodes of acute pancreatitis. Again, these patients, what are we going to see? Your epigastric pain. So like I said, it's very, very painful. Nausea, vomiting. We look again for those abnormal labs, the elevated lipase and amylase. Sonographically, so now we're looking for a pancreas areas that appear more heterogeneous. So in areas, that are really inflamed, we aren't getting that nice smooth echo texture. It looks more spongy. It's definitely thickened, so instead of having a nice thin, body and neck, the pancreas becomes enlarged, becomes thickened. That thickening, could be, I hate to say it, could sometimes maybe only affect the tail. Usually probably not, because like I said, majority of them are involved are stone, being lodged somewhere, in that distal CBD or near the ampulla. So if the blockage is here, it's going to affect, the entirety of that pancreas. So we're going to have, dilatation or damage, of that pancreatic duct through the entire course of the pancreas. So that's kind of what that show here, a big dilated pancreatic duct. So this is the normal pancreatic duct. But now we're obviously that's visualized, that's huge. So we look for things like dilatation of that pancreatic duct, heterogeneity, enlargement or thickening, sort of diffuse thickening. There might be other subtle ancillary findings as well. So there might be some fluid around this. So we might see peripancreatic fluid, particularly if we're looking around the head of the pancreas where that issue might be. So we might see fluid developing around there. So again, this is all, whenever we have any sort of inflammatory response or any sort of infection or anything going on, body's going to send fluid there to try and quell it, to try and, alleviate some of that and, deal with it. So again, we might have some fluid surrounding the pancreas as well. So here we can see a case of, acute pancreatitis. So this is very thick. It's very chunky. I want to say, think of it almost like being edematous. So it's swollen as edematous. When we think of peripheral edema, we saw some of those pictures with the legs swelling, the edema that's associated with like a cellulitis infection. That's kind of similar to what's going on here. So it's almost takes more like I don't want to say tighter stripe, but like there's more anechoic within it. So that's some of that fluid buildup, we can also see again pancreatic fluids or edema surrounding it as well. So pancreas is edematous, it's thickened, it's swollen, it's more heterogeneous. Again, look for the potential dilated pancreatic duct. So some of the complications, so we like extrahepatic collections, and edema are frequent in patients with severe acute pancreatitis. So common sites for fluid collection are going to be in the lesser sac, the anterior pararenal spaces, the mesocolon, the perirenal spaces. So this was showing, some of that relational anatomy. So this is that lesser sac. So here we can see the stomach. So it's the area between the stomach and the actual pancreas itself. So anterior in front of the pancreas, between the stomach up here and the pancreas itself. That's the lesser sac in there that we're looking for. Get some of that fluid might fall a little more dependent. So it can work out towards those perirenal spaces laterally. Um, so one of the also main things that we worry about with acute pancreatitis is the development of pseudocysts, or these parapancreatic fluid collections. So sometimes this can happen as a result of pancreatitis. The pancreatic and peripancreatic fluid collections can develop. Fluid collections may resolve spontaneously, but those that do not are recognized as pseudocysts. So here we're seeing transverse pancreas, got the body, neck, getting into the head, on-stain process. This is a large, cystic structure off the medial border of the head of the pancreas there. So pseudocysts, what is it? So it's a collection of fluid that arises from the loculation of the inflammatory process. Can also be due to necrosis or hemorrhage. So they develop when the pancreatic enzymes escape from the gland, they break down the tissue and form a sterile abscess where somewhere within that abdomen. So think about it like some of that fluids got leaked out, it's broken down, or it's escaping the pancreas, it's starting to eat some of the surrounding tissues. The body's going to try and encapsulate those enzymes to kind of stop the spread of that damage now. So it creates this little pocket and this abscess pocket. So what else do we need to know about pseudocysts? They're always acquired. So they result again from trauma to the gland or from acute or chronic pancreatitis. That's one thing I didn't mention, trauma. So patients could be involved in a motor vehicle accident, or some sort of, MVA or blunt force trauma to the abdomen. And the pancreas gets damaged, from that trauma, and you could wind up with, hemorrhage from the pancreas itself. So the pancreas could be ruptured and bleeding. And if it's ruptured also and possibly bleeding, it's also releasing those digestive enzymes as well that could damage the surrounding tissues. So pseudocysts, is, I want to say, fairly common, but it is or one of the more common things that you could see with pancreatitis. So in about 10 to 20% of patients with acute pancreatitis, you'll encounter a pseudocyst. So pseudocysts can develop long after that actual, onset of acute pancreatitis. So it can be up to 4 to 6 weeks after the onset of pancreatitis for that pseudocyst to, fully develop or to develop. So in terms of what they look like, so it's a cystic structure. It's going to be anechoic. There could potentially be some internal septations within it, stranding. So they generally take on the contours of whatever the space or shape that they're developing in. So they're not always spherical, as true cysts are. So again, that's why we, call them pseudocysts. Because a classic cyst, will be round, it'll be spherical. So a classic cyst, a simple cyst, we know that it's thin-walled, it's anechoic, and it's spherical. So no matter which way you turn on it, it still looks like a circle, it still looks spherical. Pseudocysts, again, they're not true cysts in the sense that, they don't have that same, spherical shape to it. They're also, don't have the same membrane as a typical cyst would have, but so pseudocysts, where are they located? Most common location of pseudocysts is going to be again in that lesser sac. So that space between the stomach and the pancreas, or anterior to the pancreas and then posterior to the stomach. The second most common is going to be in the anterior pararenal space. Fluid occurs, so where fluid occurs commonly is going to be in that left pararenal space more than the right. And this is transpancreas, a large pseudocyst anterior to the head and neck of the pancreas, but posterior to that distal antrum of the stomach. So this is a very large pseudocyst. So this is an image sagittal spleen now. So we're seeing a large cystic structure up by the spleen. This is a large cystic structure over by the left kidney now. So in that left pararenal space, typically again going out more towards the left side. So we see going extending out towards the left pararenal space. One of the complications that we worry about with pseudocysts is spontaneous rupture of this cyst. So this is the most common complication of a pancreatic pseudocyst, is spontaneous rupture. This occurs in only about 5% of patients, and 3% of those drainage is directly into that peritoneal cavity. So the issue with this, that pseudocyst is comprised of those, digestive pancreatic enzymes that are, again, being encapsulated into that pseudocyst. So when it ruptures, it releases, that those digestive enzymes, as well as, it's also an encapsulated abscess. So there's an infectious process part of that as well. When it ruptures, it releases all that, into the peritoneum. And then the peritoneum becomes infected and the patients wind up with peritonitis. That could lead to, such shock in the patient. Pancreatic ascites occurs when the pancreatic pseudocyst ruptures into the abdomen. So again, this is a very serious condition when that pseudocyst ruptures. So again, this is why we have to monitor, assess, ensure, that pseudocyst does not rupture, because it can have a very high mortality rate. Hemorrhagic pancreatitis. So this is when a patient has a very sudden progression in acute pancreatitis. So the pancreas, again, all of a sudden just starts getting inflamed and swells so rapidly that it actually ruptures. So rapid progression of acute pancreatitis with rupture of the pancreatic vessels and subsequent hemorrhage. So when this happens, so this is how it happens. Diffuse enzymatic destruction of the pancreas caused by sudden escape of those enzymes into the parenchyma. The enzymes cause focal areas of fat necrosis in and around the pancreas, which leads to rupture of the pancreatic vessels and hemorrhage. Clinical findings for this condition. Patients present with severe abdominal pain, very elevated amylase levels, and then their hematocrit levels, so their red blood cell counts, the hemoglobin and hematocrit levels are starting to drop as they're bleeding. So, that's a bad combination if we see increased amylase and lipase and then dropping of their hematocrit levels. So nearly half of these patients experience this process, the sudden necrotizing destruction of the pancreas after an alcoholic binge or an excessively large meal. So in terms of hemorrhagic pancreatitis, since it's blood, the characteristics of the hemorrhage will change over time. Older clots will appear more echogenic. Fresher blood will appear less echogenic, more anechoic or hypoechoic. So same like, with our DVT clots, older clots are brighter, younger clots, they're more fresh. So then the pancreas now is gonna be thickened, it's gonna be very, very heterogeneous. Um, it'll look like, well, it is due to pancreatitis, so, sometimes, this hemorrhage can be very, difficult to, denote on ultrasound. Um, so here we can see it's a little more echogenic. So like monomus pancreatitis, is a phlegmon is an inflammatory process that spreads along the fascial pathways, causing localized areas of diffuse inflammatory edema or soft tissue swellings. This may produce necrosis and suppuration. So this is pus formation. So in about 18 to 20% of patients with acute pancreatitis, this process can extend to outside the gland, so those surrounding tissues, also become inflamed as well, development of this pus. So when you see this phlegma or phlegmonomus, just think pus in the surrounding tissues. Involves again the lesser sac, so that area between the stomach and the pancreas. Pancreatic abscesses now. So again, abscesses are well circumscribed intra-abdominal collections of pus. With this, could be seen in again secondary to pancreatitis. So these abscesses develop, after or as a result of a patient having acute pancreatitis. Could also develop, after post-operative procedures. Abscesses may arise from neighboring infections, such as perforated peptic ulcer, acute appendicitis, acute cholecystitis. So why are abscesses problematic? They can spread superiorly into the mediastinum and inferiorly into the mesocolon or down to the retroperitoneum and into the pelvis. So again, this is a collection of pus abscess formation that could continue to grow and spread. So again, have to be treated with, courses of antibiotics. Um, so pancreatic abscess could be can have varying sonographic appearances. The borders could be smooth, they could be slightly irregular, but with abscesses, you should be able to have borders on it to be able to measure, the size of that abscess collection, that pus collection. And the appearances could be variable. So that term, unilocular or multilocular, refers to having septations within it. So there could be stranding or septations within that abscess. So getting into chronic pancreatitis. So chronic pancreatitis, as the name implies, it's a chronic condition. It's something that the patient's had for a long period of time, and it's a result of recurrent attacks of acute pancreatitis. So it's, chronic changes that have occurred now to this pancreas, or after chronic damage that's occurred to the pancreas as a result of multiple episodes of acute pancreatitis. This causes, continuing destruction of the pancreatic tissue, and is closely associated with chronic alcoholism as well as with, biliary disease. Patients who have or suffer from acute pancreatitis, large percentage of them will develop pseudocysts. They'll typically have dilated CVDs. You can worry about also thrombosis of the splenic vein to that portal vein. There's increased risk for development of pancreatic cancer as well. So we got damage to the pancreatic tissue itself. It's become fibrotic. It's become scarred. We'll see in a moment. Chronic pancreatitis pancreas appears very echogenic, very heterogeneous. And because those cells they're not normal functioning cells, they're damaged cells, there's an increased risk of developing pancreatic cancer in those patients. Um, so as the pancreas continues to be damaged, they'll a good percentage of them will develop calcifications within the pancreatic gland. So we can see some areas, focal echogenic areas. So this is pancreas that's very echogenic with a lot of calcifications kind of scattered through it. So just kind of get your bearings, your landmarks. There's your SMA, and then you can see the pancreas going anterior to the SMA. Because it's so fibrotic, calcified, you get compression of that splenic vein. So when we get compression of the veins there, the portal veins and the splenic confluence, because of that heavy, bulky, calcified, pancreas, compressing on that vessel could lead to potential, like I said, thrombosis within those vessels. So the echogenicity, like I said, with acute pancreatitis is going to be increased. So it's echogenic. Beyond that, because of those fibrotic fatty changes with a mixture of hypoechoic from inflammation, as well as those echogenic or hyperechoic foci, those focal areas, those calcifications. Now getting into some more, discrete lesions. Again, it's good practice to kind of just when you're again studying all the various organ systems, breaking things down, into benign versus malignant. I know boards likes to kind of break things down that way, benign versus malignant. Um, so in terms of some of these pancreatic lesions, we have benign cystic lesions. So this is just breaking down some of the several different kinds or some of the more common benign cystic lesions. Or some of the, I want to say, causes of benign cystic lesions. So these are some of the things that can cause or produce cystic lesions, benign cystic lesions. So when you think lesions, don't always think cancer or mass. Lesions refer to like any sort of structure, like so cysts can technically be considered a lesion. So like when I would write up my ultrasound reports, on a liver, like no evidence of focal hepatic lesions noted. So I would say that to say like, all right, there's nothing in that liver, there's no cysts within the liver, there's no, masses or tumors, that's all encompassed under a lesion. So a mass, a tumor, a cyst, I don't want to say stone, but like a fatty deposit, focal fatty deposit within the liver would be considered a lesion. So these are all various lesions, and kidney, stone could technically be considered, potential lesion. It's kind of stretching a little bit, but like, lesions, that term lesion has a more encompassing, um, a lot of things could be considered lesions. So autosomal dominant polycystic disease will create multiple tiny cysts to large cysts, within the pancreas. Autosomal polycystic disease will also affect the kidneys. We'll learn in a moment that's something that affects the kidneys. Could also affect the liver as well, so it can affect hepatic cysts as well. Cystic fibrosis. So it's anyone familiar with it? It's a hereditary disease that causes an excess production of thick mucus by the endocrine glands. So since the pancreas is an endocrine gland, uh, it's impacted by cystic fibrosis as well. When we learn more about cystic fibrosis, so we're going to talk, I think, a little bit about. We're definitely going to cover it in peds. Like I know I talked to you guys about it in peds, but one of the things that it does impact it, you have more likelihood of developing pancreatitis, patients who have cystic fibrosis. There's fibrocystic disease of the pancreas. So again, the hereditary disorder of the exocrine glands. So when we're talking exocrine glands, those acinar cells, they're Arsenii cells. They're atrophic, so they're poorly formed or underformed, or may be totally replaced by fibrous tissue. Von Hippel-Lindau disease is an autosomal dominant condition characterized by CNS. I have to look that up. CNS. I'm drawing a blank. Yeah, my brain. I'm blank on what CNS is. I'll get back to you guys on that. And then true pancreatic cysts. So again, organs can develop cysts. They can have spontaneous development of cysts. We often see it, more often than not on things like the kidney or potentially liver. But again, pancreas can also develop, cysts on its own. All right. All right. So now we're talking neoplasms. So cystic neoplasms can be broken down either into benign or malignant. So you should be familiar with, all these. The two types of cystic neoplasms, we have serous cystadenomas, also known as microcystic adenomas. And then mucinous cystic adenomas or cystoadenocarcinomas. These are also known as macrocystic adenocarcinomas. So we'll see in a moment a good way to kind of differentiate between these two. With this serous cystic adenoma, these cysts are very, very small. They're teeny and multiple within them. These macrocystic adenomas, they're much larger. The cysts are larger in appearance, so they're, easily distinguishable. So serous cystic adenoma, or the microcystic adenoma, it's rare, it's benign. Where do we see it? We see it found in oftentimes in older women. So von Hippel-Lindau disease, like when we get into peds, it's associated with a lot of cystic disorders. So when we see polycystic kidneys or multicystic kidneys, cysts within the liver, choledochal cysts, or some of these things, pancreatic cysts, there's this association with this von Hippel-Lindau disease. So I always think of this as like one of these cystic diseases that creates the development of these little teeny cystic diseases within organs of the body. So we can have a single tumor, that is measurable and large. So that cystic adenoma is a singleized tumor, but it's comprised of these very teeny tiny little cysts within that large tumor. So the microcystic adenoma, the serous cystic adenoma, sonography appearance depends on the number and size of those cysts. Again, those cysts are usually very small. The lesion may appear cystic, may appear more solid, or even echogenic, as the cysts are very small and more numerous. So compare that with the macrocystic adenoma or this mucinous cystadenoma. So these can be malignant or benign with or benign with the potential to become malignant. Again, these are also very rare. They're slow growing. Fortunately, these also could occur predominantly in women. And they're located typically in the body or tail of the pancreas. So with this one now, the cysts are on a larger scale. So you have that, single mass that's comprised of cysts, but now instead of being multiple or, innumerable tiny little cysts kind of all coming together to form the one mass, the mass is comprised of larger cystic areas or larger cystic structures. It might look like, septations within a cyst itself. Um, so what does it look like? The pathology features a well-defined cyst measuring greater than 2 centimeters, 20 millimeters, 2 centimeters. It contains a thick mucinous fluid with internal septations. So we see that large, cystic structure. We can see septations in it that make it look like these smaller, like kind of cysts within a cyst. It's filled with this mucinous fluid. So it may not be, nice and anechoic like that. It might be a little more hypoechoic because it's mucus, or I don't think or I don't want to say pus, but it's a thicker serous fluid, this mucinous fluid. It's thicker than, simple serous fluid. Unfortunately, again, these can potentially, become malignant. So intraductal papillary mucinous tumors. So it's a form of this mucinous cystic neoplasm. But this one originates from the pancreatic ducts itself. So it's a mucinous tumor that's growing from the main ducts. So if you think, you got that pancreatic duct, the ductal bursa on there, this intraductal tumor is growing within the duct. So it could be somewhere, we said more in the body and tail. So somewhere out here is where we're developing that cyst or where it's originating from. It's growing from there. So these are kind of like a little misleading, this picture here. Think of it growing from the ducts there and kind of expanding outward. So it's going to, distort that pancreas. So if I got a large, cystic mass growing within the body or tail in that pancreas, it's going to expand it, distort it. It's a slow growing lesion, affects both men and women. It's usually, older men and women, so, the 70s, 60s or 70s. The histology ranges from benign all the way to malignant. So with these tumors, they're going to present, as non-vascular nodules within the dilated duct. Presence of a vascular nodule and thick walls can help you differentiate benign versus malignant masses. So you have malignant masses typically have a good deal or vascularity to them or blood flow to them. So intraductal papillary mucinous tumors that arise from papillary projections that secrete mucinin and are intraductal, they're within the ducts. Because they're, within the ducts and growing within the ducts, they will obstruct and block that drainage that leads to the dilatation of the ducts. So much so that mucinin can be seen oozing from the ampulla vader. Did you hatch? Were you knocking?
I just gonna say, I thought it was crazy.
No.
Standing outside.
Yeah,
I'm good, how are you? Rashana, what did you need about Bagel?
One of the students is doing their first rotation, and she's the first one to go, so like I wasn't sure if they had a badge or somewhere, like whole process. I think you just show on the side of the department.
Yeah,
That's what.
and I mean, the doors have to be open at. What time do we have to be there? 7:30? 7, yeah, so the doors will open at 7.
Yeah.
Yeah.
Yeah. Yeah, last year, she graduated. So that the more is doing echo. Yeah. Alright, so. Neoplasms. Alright, so getting into some of these neoplasms now. So these are some of the ones that affect those eyelid islets of Langerhans cells, so the islet cells. So endocrine neoplasms. So we'll go over, B cell tumors, insulomas, gastromas, G cell tumors, rare islet cell tumors, and then non-functioning islet cell tumors. All right, so endocrine pancreatic tumors. So again, they arise from the islet cells of the pancreas, because we know these are responsible for the endocrine secretions. So there are several types, functional and non-functional. Functionals produce symptoms because they release the hormones directly into the bloodstream. So insuloma and gastroma. Non-functional tumors are the non-functional endocrine neoplasms. They form a mass but do not produce symptoms because by releasing hormones. So these tumors are classified either as benign adenomas or malignant tumors. So some facts to know: the non-functioning islet cell tumors comprise 1/3 of all islet cell tumors, and 92% of them are considered malignant. So that's unfortunately part of the reason why they say pancreatic cancer is kind of one of those silent killers. So if 1/3 of these endocrine tumors, are those non-functioning cells, the patients have no symptoms. So 1/3 of those, endocrine tumors, the vast majority of them are going to be malignant. The rate of growth of these tumors is very slow. They usually do not spread beyond the regional lymph nodes and the liver. So they could be associated with MEN1. So MEN1 is multiple endocrine neoplasia syndrome. This is characterized by a triad of organs affected. So the parathyroid, the pituitary, and pancreatic lesions will be present. So with these non-functioning islet cell tumors, lesions may be solitary or multiple or diffuse. There might be necrosis of the pancreas and the surrounding tissue that could lead to hemorrhage. Calcifications might be present in these lesions and are more frequently in the larger malignant ones in those islet cell tumors. All right, so going into, again, these are endocrine tumors now. So just kind of going a little depth now. So insuloma. So again, B cell. So B cell stands for beta. So going back to some of that previous slide, we know that the beta cells are responsible for producing insulin. So this is how this tumor gets its name. That's an easier way, for you to memorize that. So it's the most common functioning inlet cell tumor. Again, these are typically benign, which is a good thing. They often occur in patients with hyperinsulinism and hypoglycemia. What are the clinical findings? So with this, it's found in patients in their 40s to 60s, the fourth to sixth decade of life. So that's a typical target patient population. They present with hypoglycemic symptoms. So their blood sugars, are very, very low. With immediate relief with symptoms after administration of intravenous glucose. So just kind of taking like a slight step back. When tumors, like basic cancer, tumors are like the overactive growth, of a cell. It's uncontrolled growth of a cell. It's a bad cell and it's just kind of growing uncontrollably. So if you kind of think about it in that respect, when this tumor is growing in these cells, these cells are kind of growing uncontrollably, they're not functioning properly, they become overactive or hyperactive. So that's what's going on in this case, you know, those beta cells, they're hyperactive, they're producing too much insulin. So that's that hyperinsulin, I can't pronounce it, but it's overproduction of insulin. And when there's overproduction of insulin, their blood sugars are gonna be super, super duper low. That's the hypoglycemia part. So that's how we can, you know, figure out what's going on based off of their sugar levels. Other complications, you know, kind of associated with what you think of someone who has low blood sugar. You know, they might have headaches, confusion, they might have slurred speech, they might be sweating profusely, they might have heart palpitations, and if it, unfortunately the blood sugars get too low, they can enter into, you might hear someone going into a diabetic coma, or, because their blood sugars are too low. I mean, that can happen too, potentially even if you're too high, but what do they look like sonographically? They're fairly small, they're well encapsulated, they have a good vascular supply. So again, that's one of the things we look for with these lesions, the vascular supply. Some might contain some internal calcifications to it. Gastroma is the second most common functional inlet cell tumor that create the Zollinger-Ellison syndrome. This syndrome is caused by non-insulin secreting pancreatic tumors that secrete an excess amount of gastrin. So we said the gastrin was the one that controlled insulin and glycogen. I'm sorry, glucagon. So it controls insulin and glucagon. Apologize. Gastrin again stimulates the hormones to secrete amounts of that's hydrochloric acid and pepsin. So clinical findings: lesions usually affect younger males who also have peptic ulcer diseases. So with this, these G cell tumors, I see gastroma. I think gastric, like stomach issues, associated with patients who have, peptic ulcers, stomach ulcers. What they look like sonographically. So the majority of them are malignant. They're frequently multiple and or extrahepatic, so seen kind of outside, the pancreatic tissue there, or just growing off the pancreas. You can find them in the duodenum. They can oftentimes be difficult to locate. And rare islet cell tumors, some additional ones include glucagonoma, lipoma, somatostatinoma, I don't have to try, carcinoid, and multi-hormonal tumors. So with these, like I said, non-functioning endocrine tumors, they have a high incidence of being malignant. These lipomas or bipomas are also can be associated with gallbladder dilatation, some biliary disease. They're fluid filled. You might see fluid filled distended bowel loops, excessive secretion of fluid and electrolytes. Possible thickening of the gastric wall might also be present with some of these. So with the non-functioning islet cell tumors, then they make up about a third of all islet cell neoplasms. They have a high tendency to be malignant. The tumors tend to be large in the head of the pancreas, again, with a high incidence of malignancy. So metastatic disease, the pancreas. So now this is, lesions that have arisen, from other places that are now impacting the pancreas. So cancers from other locations that are now, seen in the pancreas. So this is pretty uncommon. So in general, metastases to the pancreas, again, is very uncommon. If we do see, metastases, some of the primary tumors be related to, melanomas. So certain types of skin cancers or skin cancer melanomas. Breast cancer can metastasize to the pancreas, as well as certain GI and lung cancers. All right, so I'd say the main thing, that you have to really familiarize yourself are gonna be adenocarcinomas. When we're talking about boards, we're talking about, I don't want to say real life scanning, but the more commons, things that you're going to encounter and they like to question about are going to be the main neoplasms of the pancreas and particularly adenocarcinoma. So adenocarcinoma, again, is it's now the most common primary neoplasm of the pancreas. So this is the most common tumor that you're going to encounter, with the pancreas. This one involves the exocrine portion of the gland. So the exocrine cells, the acinar cells, accounts for more than 90% of all malignant pancreatic tumors. So again, far and away the most common form of malignant pancreatic tumor. So that's what we worry about. Pancreatic carcinomas account for approximately 5% of all pancreatic cancer deaths. And is the fourth most common cause of cancer-related mortality after lung, breast, and colon. So adenocarcinomas, where do we see them? What do they look like? So clinical findings can depend on the location of the tumor. So again, if it's in the head, the symptoms will present earlier than if it's in the body or tail. So tumors in the head, they can start to obstruct the common bile duct, and those patients will subsequently wind up with jaundice. They can also wind up with hydrops of the gallbladder. So hydrops is a very large, distended, dilated gallbladder. So again, the gallbladder, bile is being produced by the liver. From the liver, again, gets sent into the gallbladder itself for storage for when it's needed during digestion. But if it's not draining out of the liver through the common bile duct, it's building up in the liver, which leads to that jaundice. So the jaundice refers to an elevated bilirubin levels or elevated bile levels within the body. That very large dilated gallbladder has a medical term to it called Cavarsier's gallbladder. So here's a patient's gallbladder, very distended and large, and it actually becomes palpable then because it's so enlarged. So a patient who has Cavarsier's gallbladder, about a quarter of them, also it's discovered that they have pancreatic carcinoma. This is just showing an ultrasound picture of a very large distended gallbladder. So this is 15 centimeters. So that's ginormous. Liver is 15 centimeters, just to kind of give you a perspective. Liver should be around 15 centimeters or even less. CT showing that very large gallbladder going all the way across. So Cavarsier's gallbladder, Cavarsier's sign. Adenocarcinoma. So if it's in the body and tail, there's less specific symptoms that are present. Some common symptoms might be weight loss. They might have pain, so maybe some, pain that radiates towards the back or pain in the middle of their back. They could potentially present with jaundice, but not necessarily, again, because the bile ducts are draining properly because the mass is further out. They might present with nausea, vomiting, So they might just think, you know, maybe pancreatitis, maybe things like, you know, acid reflux. So they might be going more the GI route, you know, as opposed to, you know, suspecting, you know, pancreatic cancer, unfortunately. So because again, those symptoms might be very mild and kind of non-specific, you know, you might just be kind of treating the symptoms, thinking like, oh, I'm having acid reflux or I'm having, you know, GI issues or problems. You might just ignore it, you know, for a longer period of time, which unfortunately gives, you know, the time for that tumor to grow, you know. So typically these tumors are larger in size and tend to invade adjacent organs and become, you know, further advanced in their staging because those symptoms are, you know, less severe and more non-specific. Um, so the mass itself, you know, we get loss of the normal pancreatic tissue patterns. So the masses, you know, they can be poorly defined in the region of the head. So it might be kind of hard to kind of really get good visualization of the borders. They tend to be darker than the surrounding pancreatic tissue. Particularly, you know, because, you know, this doesn't typically happen, you know, in child or, hey, or younger populations. We're thinking more, you know, middle age to older. So the pancreas is going to be a little more hyperechoic. So that lesion itself will be appear more hypo. Could be isoechoic, you know, making the, again, visualization of the borders a little more challenging, a little more difficult. But it's going to cause irregularities to the contours of it as it's growing. Um, Again, we also look for potential, you know, biliary obstruction, dilated CBD, dilated bile ducts, dilated or enlarged pancreatic ducts. As that tumor grows, you know, particularly if it's in, you know, the body or the tail, it could compress other structures, other vessels. So it can compress splenic vein, compress, you know, IVC potentially if it's in the head of the pancreas. That tumor can invade into some of the vasculature. So we can get neoplastic growth of that tumor into the actual blood vessels. So into the portal vein, maybe, and that could produce thrombosis in the main portal vein.
Vascular?
I'm sorry,
You doing vascular?
the abdomen. Yeah, all right. Everything's good. You're good. Let me just pause this.
You're recording it?
Yeah, no, you're good. Where's my mouse?
It didn't work today.
Yeah.
My patient.
What time do you start?
Well, I had a doctor's appointment, so I
Oh,
left
okay.
early, but
That's a little early.
I got there at 7:30 this morning, so.
That's not bad.
Yeah.
Acclimated full time,
Yeah,
weekends or no?
no weekends. We're not on call yet, though. So
Yeah,
once we get on call, it's gonna be,
occasionally, but you rotate though, right?
yeah, and it's a lot of us, so
That's good.
it's like, it's over 10 of us.
Yeah.
Yeah.
Are there any idea of pediatric boards?
Oh, yeah, we eventually have to take it, but we have a year, you know, before we can sit for it, so. Yeah,
It's gonna be a test. You gotta let me know how it is. Like I can't even imagine
I think
all the
that's-
procedures.
Yeah, I think the thing that's
Corrective
gonna get me the
procedures.
most though is the fact that like we're
The way
not
you
gonna
look at it.
know. No.
Oh, no,
like,
you're used to that
I'm used
now.
to that now, yeah. But it's the weight of like finding out whether you pass, because you don't find out right then and there.
Oh, that's right.
They say it
It's
takes
only
like
given
2
a-
months
yeah.
for you to find out, and I.
Given certain times of the year.
Yeah. And yes, I think they only offer like twice a year,
Yeah.
so it's just like, I don't wanna have to wait 2 months, and I feel like during that time, I'm gonna go crazy, wondering like, do I still need to study? Like, am I okay? I don't,
Yeah.
that's gonna drive me crazy.
I don't know why they do that.
So, but yeah, everything's great. Everything is going the way that
It's meant
should be
to
going, yeah, right.
win chess.
And we're
You know.
like this now, like Jess is my girl, we're leaning on each other. You know, it's very catty there, so, you know, people, and some people don't like some people, and, you know, it's just, it shows. So sometimes there's tension there, but me and Jess, you know, we have the same exact schedule, so it's just,
Yeah, it's good.
yeah, it's
Yeah.
great.
It's like Sydney and Cage are working together now.
Yeah.
They're doing their shifts and
Yeah.
they've teamed up. It's funny.
That's
how
what I
it
said
worked
in
out.
class. I said it's funny how them two are together and we were together,
Yeah.
but that's how it was in class too. So, you know,
Worked out.
it is what it is. It definitely worked out, because now I'm not even scanning left anymore. I'm completely right-handed. So I left lefty alone because I'm like, I don't need this
You don't need
scan
to
left,
necessarily for
yeah,
kids.
not at all.
But you got some big kids though, I'm sure.
Yes, I was just telling Shauna earlier this week, I had a 15-year-old who was like 300 pounds. And it killed my shoulder, like trying to crash, trying to get subcostal, trying to get ankles, it killed my shoulder. But, you know, I just did what I could do. I'm like, this kid needs Definity, but yeah, they don't do Definity there, so, no, they don't do Definity at all. At all. Like, I guess because, you know, most of the 9 times out of 10, the patients,
Yeah,
you're gonna see their images,
yeah,
but-
makes sense to stock it, I guess.
I guess not, I don't know, but that kid is, I mean, he had good parasternals. But that's all he had. He didn't even have a notch, like no subcostals. Like, so you couldn't get, you know, to see if there was like any ASD or VSD or anything. Couldn't get no ankles.
Yeah.
Not even a 4-chamber.
Yeah, his trust is huge.
Yeah. So it was already
That's what it is, I guess.
That's far and few though. So most of the time the images are great. I mean, I like today my patient I had his images he was 7.
Yeah.
I mean, beautiful images, no pathology. It was just great. Amazing. I don't want to get into your is this a class? Can be a class. Is this a study session?
Kind of. One-on-one, yeah.
I was thinking, I was like, practice.
Yeah, she was here. I'm just recording for everyone. So yeah, she came to study.
Most guys don't have to go back. He's posting it for us to watch, instead of watching it later. Watch it live.
Good. Yeah, that makes sense because I don't know how long where's Jen? Why is Jen not doing it?
She's doing some site visits today, and she's got a couple things to do from home, but
She didn't finish up our pathology, so. Our test is next week.
Yeah.
this mouse is
Teamwork.
dying,
Are you
dude.
first or second year? First.
Okay.
Well,
I know.
welcome.
I'm looking at you like, I'm gonna be here one day. I'm glad it's going well. There's no,
Well,
future's bright.
you gotta talk to who's at Nemours? Brittany and
Something.
Sutton. Yeah. Yeah. Are you interested in adult or ped?
I don't know, I think he,
Yeah.
yeah, I haven't chatted, like, I haven't seen anything kid related yet, but I, like a daycare, I have a little sister, like, I just like kids, I like the environment, so we'll see.
Are they gonna rotate through Nemours, the general?
They do, yeah.
Okay.
They do a first year.
Okay.
Yeah.
What do you get? I mean, I did Sutton and Brittany.
Yeah.
Actually, we ran into them, cause I remember Sutton and Brittany had got hired for a PRN, but Brittany said they had offered her a full-time position, and I think she said it's 4 10s, so she don't have to be there 5 days a week. She's only gonna be there 4, which is good for the baby. So she was like, yeah, everything just worked out good for her. So
It all just works out.
it works out. I would have never imagined. So I don't know how it is for general though, but
Right, fingers crossed, it works out too.
yeah, it will.
It does. Like it's actually kind of, I don't say frightening, but like it's like you take a step back and just like let things kind of work their way out, and they do. Like
They
people-
really do.
they really do. Everyone
don't
winds up
be
exactly
afraid.
where they want to be and where it works for their lives. And
Don't be afraid to like take your own initiative.
Oh, right, yeah.
Cause if I would have never reached out to Lisa,
you don't have to worry about initiative with her.
cause if I would never reach out to Lisa, I would have been lost in the adult world. Like,
Yeah.
yeah, so yeah, don't be afraid to do that. Did Sophia not ever find a job? I remember.
Yeah, Sophia's at Delaware Imaging Network.
Okay.
Yeah.
Cause I know most of them went to Christiana, right? Like Jay.
Jay
Sarah.
and Sarah, Christiana, at the main hospital. Wilmington, Lexi's at Wilmington.
Okay, good.
And then MFM is what's her name? Red hair. Catherine.
Mhm.
And then Nemours is
Certain names.
Sutton and
Brittany.
Brittany.
Oh, we all got jobs. Great.
Yeah.
That's really good.
I'm like, got that first paycheck. Like,
Oh, the first real one, because we came in the middle of a pay period, so our first one was like half of what it was.
and it really still was like.
It was definitely good, for
Right.
sure, but that full paycheck, I'm like, yeah. I finally got my tattoo, I kept on telling you I was gonna get, because I could afford it now.
Right.
Remember, I was like, I was gonna get the one in memory of my mom. So she loved elephants, butterflies,
Aw, I love that.
flowers,
That's so
she
good.
loved charmed. So, I was like, I finally afford it, this thing was $900.
I know, I'm trying to say,
So-
well.
Is that one
if you
sitting?
have this paycheck,
One
I'm still
sitting.
thinking about that.
And I went through hell. I didn't use no numbing cream, which I should have, because it was hard.
Hmm.
But I got through it, so it's all that matters.
It wasn't it harder? Analogies.
That's painful. Well, no, it is more painful. It's not painful.
was shortened, boy, this was a drawn out page.
Yeah, this was for sure. This was a psychological, like you said, very psychological here. Especially them vascular classes, I couldn't stand it. Long lectures, 200 slides. No, hate it. All right, Daniel.
Alright, I'll see you, yeah, definitely, take care.
Nice meeting you.
No, good luck.
Yeah. Yeah. Good luck. Great. Tana.
I need batteries, I don't even know if I'm recording or not anymore, like.
Wait a minute.
Yeah, we're still going strong, alright. So again, with adenocarcinoma, you can look for a dilated pancreatic duct. So again, take a AP measurement inner to inner for the diameter of that pancreatic duct. Um, so yeah, adenocarcinoma. So what are the survival rates for this pathology? So carcinomas of the pancreas is rare before the age of 40. Majority of patients are older than 60 years of age. Fortunately, prognosis is poor with a median survival time of 2 to 3 months, and then 1 year survival of only 8%. So parapancreatic or retroperitoneal neoplasms. So these are some neoplasms or growth around the area of the pancreas or in the retroperitoneal spaces. Some additional cancers, that might manifest. Lymphoma. Lymphoma, again, is a malignant neoplasm. Most frequently, parapancreatic neoplasm. Sonographic findings, we see intra-abdominal lymphoma may appear as a hypoechoic mass or with necrosis, and then a cystic mass in the pancreas itself. Malignant lymphoma with enlarged lymph nodes are seen here in this picture. So I could see, you know, it looks like, you know, some enlarged lymph nodes kind of adjacent to that pancreas there. Actual lymphoma itself. It's like, yeah. Showing you how I'm thinking that the actual lesion itself is not there. These are look like some large lymph nodes, anterior to the tail. So since lymphoma grows within the retroperitoneal space, it distorts some of the vessels. So the mesenteric vessels may be displaced anteriorly instead of posteriorly, because that mass is growing from kind of like deep within and pushing forward, pushing upwards. Multiple lymph nodes are seen along the pancreas and duodenum at the level of that porta hepatis. Lymphangiomas. These are rare benign tumors of the lymphatic system. So these are most often thin-walled, homogeneous with small cysts. Those cysts can have septations within it, as well as internal debris or calcifications. And then other tumors that are kind of growing, you know, in that area of the pancreas could be a cystic teratoma. So cystic teratoma is like, you're gonna hear this definitely in your OBGYN class or GYN class. Cystic teratomas, they're rare, they're benign tumors. They're particularly found in children and young adults. So these tumors, they're basically comprised of all different kinds of tissue. So there could be some bones, some tooth, some hair. So benign cystic teratomas, you might hear these as like I forgot what's the term for it, but they're comprised of like all different kinds of cellular tissue, or like I want to say cellular tissue, but like they're tumors that are made up of like different say parts, but like in the way they are, they contain bone, they can contain tooth, they contain hair, they can contain like other bodily tissues within it. So they're very heterogeneous in appearance. They're often contain, you know, things that are calcified within it. They could have solid fat components to it, so they're very complex. So then just kind of getting into some surgical interventions, or namely the Whipple procedure. Just kind of just tying it all together. So Whipple procedure. Once again, just familiarize yourself with what the Whipple procedure is, you know, what it's done or why we perform it. It's a surgical resection of the pancreatic head and the periampular area. The remaining normal pancreatic tissue is attached to the duodenum. So another name for this procedure is pancreatoduodenectomy. Duodenum, pancreatoduodenectomy. It's what are the perioperative criteria? So there has to be absence of extrahepatic metastases, meaning that tumor can't be staged outwards, you know, affected the lymph nodes. It hasn't spread past, you know, into the lymph nodes. It's not spread into any of the adjacent tissues or structures or any adjacent organs. So the mass itself has to be still within the pancreas or the head of the pancreas. We're going to evaluate the vasculature to ensure that there's no tumor that's grown into the vasculature. There's no thrombus within the vasculature. They look at the arteries as well, the celiac and the SMA, to evaluate patency in those as well. So patient would receive this procedure to relieve obstruction of the biliary tree due to the malignant tumor. So how is it altered? The pancreatic head, gallbladder, portions of stomach and duodenum are removed. The common bile duct is ligated, superior to the cystic duct, and then connected to the jejunum, distal to the pancreas. The remaining pancreatic tissue then is attached to that jejunum. So here we can see where, they ligate this, the cystic duct that, they connect, I'm sorry, the CBD is ligated, they take the cystic duct and connect it directly into the jejunum, or that proximal part of, the intestine there. The remaining portion of the pancreas and then is connected and attached directly into, the intestine. So basically then we're bypassing, and then the stomach itself is actually connected directly, to the intestine there itself. So they're basically removing the structures in that area. This is kind of like a little more detailed, picture of it here. They're bypassing all this. They're kind of trying to bypass, that area where the head of the pancreas is. So stomach now is connected here to the jejunum, or what duodenum goes into the jejunum here. The duodenum is the first part of that small intestine. And you can see the common hepatic duct draining the bile, connecting directly in. The connection of the pancreas, to the intestine. All right, so going over some review questions. So in terms of pancreatitis, main causes of pancreatitis, gallstones, alcohol abuse, going to be your two main causes. So clinical signs, these patients, they present with intense epigastric pain, nausea, vomiting, might have fever, there's some of their symptoms, clinical signs. We look for the amylase and lipase, elevated amylase, elevated lipase. Sonographic appearance, the pancreas, appears heterogeneous now. It's got more of a spongy architecture to it. It's thickened. With hemorrhagic pancreatitis. So this is when we actually have, breakdown of the vasculature and bleeding within the pancreatic tissue itself. So those releases of those pancreatic enzymes could then also break down some of the blood vessels, leading to bleeding within the pancreas. The hemorrhagic pancreatitis, the pancreas can appear very echogenic now. It also looks, inflamed as well. Phlegmous pancreatitis. So now we have that pus collections that's developing, with the pancreas, and it's spread to the adjacent surrounding tissues. What are the causes and findings of acute pancreatitis in children? We discussed that. So in children, we might be more of a result of acute pancreatitis. It would be some of those autoimmune diseases like autosomal dominant cystic disease or von Hippel-Lindau disease could result in pancreatitis in children. Cystic fibrosis. So definitely put cystic fibrosis in there would be a primary cause. Actually, cystic fibrosis is probably the best example. So with cystic fibrosis, it causes thick mucinous secretions. Those thick mucinous secretions could block the ducts, obstruct the ducts, and lead to development of pancreatitis in children, for sure. So let's say cystic fibrosis, put that in there, definitely cystic fibrosis. Some other structures that maybe may confuse pancreatic cyst in the left upper quadrant. So if a patient has a pseudocyst, left upper quadrant, other things that might be confused for a pseudocyst, you know, maybe there's an abscess there, maybe there's a renal cyst, maybe hydronephrosis, maybe you see a dilated ureter in that area. I'm just trying to thinking a little outside the box here. What are the causes, clinical symptoms, and sonographic findings of chronic pancreatitis? So chronic pancreatitis caused by repeat episodes of acute pancreatitis. Clinical signs and symptoms, again, you know, epigastric pain, weight loss, nausea, vomiting, some of those typical symptoms we see with acute. The pancreas appears very bright, very echogenic. Talked about, so discuss some of those findings now for cystadenoma, adenocarcinoma. So let's go back. Cystadenoma. So we had, again, a couple different types of cystadenoma. We had the serous, which is the microcystic. So these tumors are comprised of multiple tiny little cysts. Versus a mucinous cystadenoma, which is much larger. And then the cystic components will have these intestinal substations. Sometimes it'll make it look like it's comprised of, like, you know, larger individual cysts. And then we had mucinous tumors or cystic neoplasms, the intraductal ones that grow off the actual duct. So those would be within the actual pancreas itself. So these guys might be, you know, kind of, they're within the pancreatic tissue itself, but might be more exophytic in the sense that they kind of distort and grow outwards. Whereas the intraductal ones are within the actual pancreatic tissue itself. So you might see pancreatic tissue, like, you know, on both sides of it. So adenocarcinoma, again, by far and away the most common neoplasm in the kidney, or in the pancreas. These are, again, malignant, primarily malignant. Clinical signs and symptoms. Some of that will depend on, you know, the location of that adenocarcinoma. They typically appear hypoechoic to the surrounding pancreatic tissue. Since it's malignant, they're going to be vascular. So you put some color on, see some vascularity to it. And if they're in the head of the pancreas, that's predominantly, you know, where most of them do form, you know, is in the head of the pancreas. Those patients will have more severe symptoms. They'll typically wind up with jaundice, you know, because of obstruction of the bile duct. So they'll present with more severe symptoms. So we can tend to catch those earlier when they're in the head of the pancreas. What are the types of pancreatic islet cell tumors? So we had insuloma and then gastroma were the two main ones. The insuloma, you know, affecting the B cells, the beta cells, the ones that produce the insulin. What are the occurrence and sonographic findings of metastatic disease? So occurrence is very rare for metastatic disease in the pancreas. So it's more likely going to be an adenocarcinoma, primary tumor. So metastatic diseases, we might look for, you know, surrounding pancreatic fluid collections. in terms of, but really, when we're talking metastatic disease, to characterize metastatic disease, unfortunately, like really ultimately at the end of the day, you have to biopsy these masses, these tumors to get, that adequate diagnosis of metastatic disease. Let's see. Yeah. Sure. Right here.
Good thing in chat, but
You're out.
gotta get this show on the road.
Yeah.
Thank you for doing that for us.
Yeah. It's gonna be a little bit more at the end, but you got it.
Great. I
Yep.
sat here so I don't have to watch you back.
Yeah.
That's too accountable. That's teach in real time. Thank you, Dan.
You're welcome. All right. Start recording. So again, just kind of like, breaking down, the material to kind of help and, guide you guys and kind of just breaking down and understanding and studying. Um, when you get questions, questions on the exam, just kind of break it down as to, what's the most common or what's the most likely, things to occur. Um, like pancreatitis, most likely, patients who do have pancreatitis, particularly we saw on the slide, like chronic pancreatitis, there's higher likelihood that these patients are going to have pseudocysts. So we said about 25% of patients, with chronic pancreatitis have pseudocysts. So that's something that we worry about now. So again, just kind of think of most common, most likely to occur. Um, that's gonna help you to kind of break down, some of these questions. Um, so go over, again, look at, focus on, in terms of like, the pathology slides, go back. Uh, like, with the pancreatic pseudocysts, when do we see them? We see them in cases of acute pancreatitis. We see them in cases of chronic pancreatitis. Um, you know, it's the sonographic findings. Like, what does it look like? Go back here. We're on the wrong one. Sorry. Sorry, share screen. Share. Share. Again, familiarize yourselves again with the most commons. You know, where do we see, where's the most common location for a pseudocyst? In the lesser sac. So again, most common neoplasm, adenocarcinoma. Um, Again, acute pancreatitis, we set up to, 40% potentially could have pseudocysts. So when do we see pseudocysts? We see it with chronic pancreatitis. We could see it with acute pancreatitis. Um, a lot of the test questions are multiple choice. There's going to be a couple of labeling on there. So labeling, your pictures for your pancreas, a sagittal pancreas, as well as, um, a transverse pancreas. Um, so with that, you know, labeling, it's going to be, that nice picture that we get here in lab, where you could see, sag pancreas. We have, portion of the neck. You see the uncinate process. You got your vessels. Familiarize yourself, when you're in sagittal, what the orientation is. That the upper part or the left of your screen is superior, inferior on your screen, anterior, posterior on your image. Um, recognize, the structures that are anterior, um, to the pancreas as well. So, we see, you know, distal antrum of the stomach anterior, to that, the pancreas there. Recognize that we see the liver, in the pancreas as well. So in that long pancreas, we can see a portion of the liver as well. Be able to, recognize, dilated pancreatic ducts, potential causes of dilated pancreatic ducts, you know, um, again, be able to label your structures in both, the sagittal pancreas view as well as your transverse pancreas view. So all the things that we've gone over: aorta, IVC, SMA, portal confluence, portal vein, splenic vein. Familiarize yourself with, again, the enzymes. So lipase, amylase, you know, um, so particularly, amylase. Um, so go back to that chart. So when amylase, doubles, that could potentially indicate, it's twice the normal levels, that usually indicates acute pancreatitis. So again, we're looking at amylase, we're looking at lipase. Amylase, we have serum as well as urine amylase. Let's see if I got that chart. Let's see. So again, with some of the masses and lesions, so go back and look at, you know, your islet cell tumors. So like again, it's gonna be, you know, the most, study the most common ones. So with your islet cell tumors, we had an insuloma. So affecting, those uh the beta cells with the insuloma, like because it's, causing overproduction of insulin. Think about like, how that's going to affect the patient, So a lot of this, we're going to start getting you in the practice of like when you're looking at these board questions, like the test questions are going to be more indicative of like registry type questions. where they'll give you patient information, kind of patient background. You have to understand like what the signs and symptoms of that patient could potentially be indicating, in addition to the sonographic findings. So like, for example, like someone, who has an insuloma, patient might present with some of the things of like, uh, that we would see with that particular type of tumor. So like confusion, headaches, things that may associate with having low blood sugar levels, palpitations, headaches, confusion, you're disoriented, elevated insulin levels, low blood sugar levels. So all they put those things in there in addition to, the ultrasound also was revealing like a small, like a hypoechoic mass seen in the pancreatic tail, um, with the patient's symptoms, and they want you to make that connection that, those symptoms are associated with someone that's got, high insulin levels or low blood sugar levels. All right, that's an insuloma, that's an islet cell tumor, to make those connections. So that's the way you have to kind of do your studying and break it apart. Um, see, in terms of like, relational anatomy questions, um, let's go back. You could focus, some of these slides, and that should be, more than enough to help you with, the relational anatomy. Let's see, be able to answer these questions. Sharing this one. Sorry. Share. Share. Yeah, so these couple of slides with the relational anatomy. Particularly know your vascular landmarks and with relational anatomy. What serves as some of the borders. And then if you want to break it down, the head. Like understand, like just get comfortable, like know that, the head, it's anterior to the IVC. To the, right of the portal confluence. So you visualize, that when you're thinking about it sonographically and you got your picture sonographically, the head is to the right of that portal confluence. It's inferior to the main portal vein. We know the main portal vein is running up towards the liver, so that's going to be superior. It's going to be inferior to that. It's medial to the duodenum, lies in the lap of that C loop of the duodenum there. We know that the neck, so the neck sits anterior to the portal confluence. And then it's superior, to the main portal vein. I'm sorry, superior to the superior mesenteric vein, so SMV. Uh, Portal confluence there. Let's see. Body of the pancreas. Again, splenic artery makes that superior border, the pancreas. So splenic artery there. creates the superior border. Splenic vein we know is posterior, so it's behind the pancreas there, the posterior border. Got the distal antrum, the stomach anterior. Again, so just again, just kind of familiarize yourself with these, you know. I mean, this is a good thing to kind of just if you want to just kind of break it down, you know, break it down segment by segment. All right, tail, splenic artery superior still, splenic vein, posterior, stomach still anterior, you know. And that tail runs all the way out lateral, um, extends towards the splenic hilum. Again, just be familiar with your anatomy for the ducts. Ductus Wirsung, main pancreatic duct, ductus Santorini. Familiarize, you know, where they come together, ampulla levator, sphincter of Oddi, common bile duct joins the main pancreatic duct at the ampulla levator where it drains into the second part of the duodenum there. So again, for relational anatomy, you know, you can do those. These are some good slides. So those slides here, the head, spontaneous process, neck, body, tail. So this basically is also explaining some of that as well. Yeah. Um, so again, just go over also start familiarize yourself again with the cells and the secretions, the exocrine and the endocrine secretions. So exocrine secretions are enzymes, endocrine secretions are hormones. So also, you know, be familiarized with that. So, you know, so the endocrine stuff are not enzymes. The endocrine stuff are hormones. So endocrine functions are hormones. The exocrine are digestive enzymes or enzymes. So if you see something like talking about pancreatic enzymes, you know it's exocrine, and you know those are the acinar cells. Just kind of looking again, it's, focusing on pseudocysts. So you see a large, cystic collection. This one is coming off the pancreatic head here. So this is, down here in this anteropararenal or near the head of the pancreas. Again, more likely it's going to be in this lesser sac, so anterior to the pancreas in the lesser sac between the stomach and the pancreas. Here we see a large cystic structure. So again, most likely, what is this going to be? We see a large, fluid-filled cystic collection anterior to the pancreas in the lesser sac, the most common location where it's going to be. Posterior stomach, anterior to the pancreas. You just, again, have to put all the kind of pieces of the puzzle together, Patient presents, with symptoms of acute pancreatitis or known pancreatitis. We see a large fluid collection anterior to the pancreas in the lesser sac, most likely a pseudocyst. Get into pseudocysts, think critically, you can identify the pancreatic region of these pseudocysts. So this is most likely going to be, out towards the tail of the pancreas because we're over, this is again, the spleen now. So we're all the way out in the left near the hilum of the spleen where the tail of the pancreas would be. And we're seeing, kidney here. So we know right kidney is all the way out, by the liver. You guys have imaged right kidney. That's nowhere near the pancreas now. So this has got to be left kidney. And we're seeing a large cystic structure out by that left kidney here. So again, this is that pararenal space over by the left kidney there. So it's going to be probably, distal body or more likely tail of the pancreas. Again, we worry about rupture of these cysts, hemorrhagic pancreatitis, it's rupture of the pancreatic vessel, subsequent hemorrhage, and with rapid progression of that acute pancreatitis. Again, the enzymes have broken down the vessels, they're bleeding now. So we can, tell this, again, like I said, in these patients, they have severe abdominal pain, they have, high elevated amylase, but they also have that drop in hematocrit because they're bleeding. So when we have lower drop in hemoglobin and hematocrit, this now starts raising the warning flags. All right, we got hemorrhagic pancreatitis going on. So again, it's just recognizing, being aware to be able to put all those little kind of pieces of it all together.